have for tonight. What we're going to talk about tonight is a couple of topics. Certainly there's a jillion things that we could talk about, but there are a couple of things that are going on that I think are important for our organization, for our docs. So we're going to start with those. We're going to talk about URAC accreditation and quality improvement projects. We're going to spend a little bit of time talking about some of the CMS benchmarks for the ACOs, because those are available. We're going to talk about the difference between wellness and illness and what that means for some of the things that we do in the office, and especially looking at what CMS wants to do as time goes on, and what the government wants to do, frankly, in terms of changing the healthcare delivery system. And then we're going to spend some time talking about transitional care management, which is an important part of what we'll be doing. I have thrown a couple of pictures in here just to sort of kind of break things up a little bit. I'm not trying to throw anybody off with this, but they'll show up at sort of odd times, like now. Pensacola is the home of the Blue Angels, and we know that the Blues were grounded during the sequestration time frame. We were grounded as well. We had significant cuts in terms of what we could make during that period of time. The Blues fly the F-18, which is a tactical fighter, multi-role, and it tops out at a speed of Mach 1.7. URAC accreditation. URAC stands for the Utilization Review Accreditation Commission, and this is an independent not-for-profit that started in 1990. Why they're important to us is they offer a national certification and accreditation in recognition of some of the things that we do. They focus on education, measurement, and accreditation, and essentially from our standpoint, what they do that's important is they validate our commitment to quality and accountability in our healthcare organization. URAC has become an industry standard that's as well accepted as NCQA or JCO. And actually for organizations like ours, it's much more flexible. They have 30 different programs of accreditation, and Health First Network is pursuing two areas. One is in credentials verification, and the other is in Health Network. Health First Network has essentially functioned as a credentialing organization almost since we started back in 1985. We've gotten proficient at it, and we've been able to offer this service to some other organizations as well. This will give us an opportunity to become nationally accredited as an organization that does credentials verification. And also, we came together in 1985 to serve as a health network. And as we move forward into more robust clinical integration, accreditation will actually provide us a framework for being able to do that. It will give us a chance to sort of look forward to what we want to do, put proper things in place, and be accredited for doing that. Bear in mind that in both of these instances, we're seeking national recognition and accreditation for areas that we have been developing proficiency in for a long time. Part of the URAC accreditation process involves developing QIPs, which stands for Quality Improvement Projects. This is nothing new. Everybody's familiar with this process, this cycle. We borrowed it basically from heavy industry, and we're attempting to adapt it to the healthcare industry, which is not so easy. But basically, what it's designed to do is to document our ability to identify areas that need improvement and our ability to develop and implement programs to bring the improvement about. This is a cycle, and so once you do it, you have to do it again. So it has to be designed so you can measure, compare, remeasure, and then take appropriate action depending on what the results are. Our QIPs, and we have two, are built around our ACO population. Again, we have to think of the ACO in terms of sort of an experimental workshop where we're trying to find out what works and how to make it work. The ACO program is designed with quality measures built in that we have to meet. And certainly 2 areas of particular interest for us are fall risk and depression risk in the elderly. These are both ACO quality measures. And interestingly, these also affect a number of other measures in sort of a cascade kind of a thing. So we expect to be able to improve our performance, not just in these 2 areas, but in additional areas as well that have to do with patient satisfaction and things like that. One of the advantages we have is that one of the things that happens with our ACO patients is they all are given a personal health assessment initially when they join. Now, all of them don't fill it out, certainly, but enough of them do. And part of what's covered on that is fall risk and depression risk. These are preliminary, and those who fail this initial screen at the PHA level will be followed up with additional studies and followed up also with appropriate care plans as well. We have care coordinators through our ACO. We have 3 who are working currently with physician offices and with the patients as well. So they'll be key in moving forward with these things, and we're going to try to provide as much support as we possibly can to our physician offices. If you've failed the initial question on fall risk, what we're going to do is follow that up with what's called the TUG test, which stands for Timed Up and Go. This is designed to be done and recorded in the PCP's office, and if it's appropriate, a care plan implemented as a result of it. The way the TUG test works, basically, this can be done by anybody in the office, and we will have available any additional training that we need for this, but it's pretty straightforward. The patient starts out sitting in a chair. They get up, walk 10 feet, turn around, walk back, and sit down again. And they're timed. And if this takes longer than 12 seconds, they're considered to be at increased risk for falls. And this has been well documented in the literature. For the depression questions that are currently available on the health risk assessment, we're going to follow it up with the Personal Health Questionnaire 9, PHQ-9. This is aimed specifically at depression and is a very good test at a screening level. Again, if patients fail the PHQ-9, then they'll need to be seen by one of the providers in the office with appropriate care plan and follow-up set up. If they pass the TUG test and pass the PHQ-9, then they're just going to be set up for rescreening at another date, about a year down the road, and we'll get to that a little bit later as well. Bear in mind that we will be able to assist at each of these steps, so we hope this will be relatively easy for our PCP offices to do. Just thinking about the numbers on this for a minute, we have about 9,000 patients currently that are attributed to our ACO. And by going through the PHAs, we actually were able to identify 2,200 of the PHAs, which gives us more than a statistically significant sample to work from. From those, we've winnowed it down at this point to about 318 that failed one or the other or both of these tests. So our interventions will be primarily targeted at those 318 plus or minus patients. This is an F-15. This is a tactical fighter that's currently flown by the Air Force. It's been around for a while, but it's still a standard. And this one tops out at about Mach 2.5. They really won't tell you how fast it goes. We're going to switch gears here a little bit, and we're going to talk about ACO quality benchmarks. This is important because it sort of lines up what we're going to have to get used to doing as time goes on. What I have here is a link that takes you to the CMS description of the quality benchmarks and how those function. And what I'm going to try to do is I've got a number of links sort of sprinkled through this presentation. I'm going to pull all those together into one document, make those available after we check to make sure they all work. And we'll put those out probably on our website. The ACO benchmarks are based on PQRS, And if you've been following things, there's PQRS, there's HEDIS, there's Leapfrog. There are a number of organizations and groups that are putting out quality standards. These are all eventually going to coalesce into sort of a single universe of quality measures that are aimed at different parts of the delivery system. You may recall that when the ACO law was first written, there were 65 quality measures, but people squawked to the point where they reduced that number to 33. They're distributed over 4 domains, and this is basically what it looks like. There's a domain, patient care, giver experience. There are 7 measures there. Care coordination and patient safety, 6 measures there. And there's one measure here that actually counts for double score, and that's the EHR adoption rate. So the more of our physicians who are on EHRs, we get double points for those. In preventive health, they have 8 measures. And then in at-risk populations, and this is where the clinical stuff comes in, there are actually 12 measures there, but there are 2 composite measures. Diabetes is a composite measure that is made up of 5 related measures, and you have to hit all 5 of those to get points. This is an all or none. Coronary artery disease also has 2 related measures, and you must hit both of those to get any points as well. The target for these is relatively low because it's going to be hard to get all 5 measures, but we're really supposed to get as many as we can. And again, to get points for these, you have to get all 5 of them. The scoring on this is basically by domain. So in each domain, you have a certain number of points that are achievable, and they take the total number of points that you achieved, divide it by the total of points available, times 100, and that gives you your raw score, which is a percentage. CMS has already determined percentiles for comparison. So after you get your percent score, you'll be assigned into a percentile, and the way this works is if you get 90th percentile or above, you get 2 points. That drops down to 0 points if you are below the 30th percentile. So you have to hit 30th percentile on these things to be able to make points. And you have to be able to make points to qualify for savings. If you save a ton of money in the ACO, but don't hit the quality measures, you don't get any of it back. So these become critically important. Each ACO will be given a blended score that will determine where we fit in the savings categories. This actually is a Sukhov Su-27. This is an air superiority fighter flown by the Soviets. Now it's actually the Russians. And right now these are flying over the Ukraine border. This one tops out at about Mach 2.5. I'm going to give you a couple of examples of how the scoring actually works for these things so you get some kind of idea. With some of these things, like they use the CAP survey data, and those are things like, do you like your doctor? Did you have trouble getting a timely appointment? Those kind of things. And those, whatever score you get is the percentile that you rank in. So if 30% of your patients say they like you, you'll score at the 30th percentile. The diabetes and coronary disease, we'll look at those for a minute. Again, diabetes is 5 measures. To hit the 30th percentile, you have to have a raw score of 17.39%. Now that's pretty low. The 90th percentile is only 36.5%, which basically reflects the difficulty of trying to get all 5 of these things lined up. Same thing is true with coronary artery disease, although it's only 2. There are some measures that are sort of upside down and backwards. Hemoglobin A1C greater than 9%. The greater number of people you have with an A1C over 9, the poorer your score. And in that one in particular, if you have 70% of your patients with a hemoglobin A1C over 9, you'll be at the 30th percentile. That goes sort of reverse to at the 90th percentile, it's 10% of your patients with a hemoglobin A1C of over 9. So that gives you a rough idea of sort of how this is going to work and what we'll have to do it. This is actually a MiG-29. This is another air superiority fighter that the Russians fly. And this one actually tops out at about Mach 2.3. Now we're going to shift gears again and we're going to talk a little bit about wellness and illness. And I don't mean this to insult anybody's intelligence, but I think these things mean something different in our current milieu than they have in the past. And I think we have to understand how these things are different and what we have to do to make these things work. Bear in mind that a lot of this has been generated since the passage of the PPACA. And again, they're very intent on making sure that patients are getting good experiences and good care. They want the populations healthier. They want it done at the lowest per capita cost. One of the things that they have done is they've put in some wellness visit codes that are billable. There are 3, and I think it's important to understand how these work. G0402 is the Welcome to Medicare Preventive Visit, also called the IPPE, Initial Preventive Physical Exam. This can only be done once, and it has to be done within the first 12 months of a patient's eligibility for Medicare Part B. If you miss that, you don't get to charge this one. That's gone. This particular visit is pretty complex. It requires a review of medical and social history. You have to look for the potential for depression and other mental conditions. You have to review the ability of the patient to be able to live safely in their home. And this is looking at the ADLs and IADLs, fall risk. You're supposed to record height, weight, blood pressure, BMI, and a vision test. And then you have to give counseling and education that's based on what you find in terms of risk factors and exam findings. You are supposed to make referrals into related services in the community to help achieve wellness. And you also are supposed to set up a plan for their continuing immunizations and screening procedures. Now, the G0438 is the annual wellness visit initial. This also, you get one of these in a lifetime. And if you did not get an IPPE in the first 12 months, then what you'll do is you'll do an annual wellness visit initial. Interestingly, this covers other areas that are not covered in the IPPE. You have to use a health risk assessment tool of some description for these visits, the annual wellness initial and the subsequent. And these are fairly complex. They expect you to come up with a 5 to 10 year plan for how you want the patient's care to progress, and it needs to be documented. And all of these, the Welcome to Medicare, annual wellness visit initial and subsequent, require a written or printed document that is given to the patient that outlines what your recommendations are and what you think they need to be doing. All of these things, each of these elements has to be included in these visits to be able to bill for it. So these things have to be documented. And again, these are not simple visits. As noted, what's required for the IPPE and the AWVs are a little different, and all of them require that written or printed document. And I think it's important that we understand that. If you ever get audited, you may never, we hope that you never do, but if they come back and want to take a look at your IPPEs and your AWVs, you're going to have the documentation. This is what they pay for it. So obviously, CMS thinks these are relatively valuable. Again, they're not simple, and they require a lot of work on the physician's office staff and the physician himself. This is a series of links that describe each of these visits, and it also has a checklist of prevention measures and screening measures that you're expected to be addressing with each of these. And again, I'm going to put all these together. One of these did not work when I tried it, so I'm going to have to go back and redo it, but I'll get the right links out to you so you can take a look at it so you understand a little bit more about what we're up against. Everything that's not a wellness visit is an illness visit, And I think this is going to be a really important distinction as we go on, because we're going to be expected to do all the wellness things and all the illness things. We've all had experience with the Part C Medicare programs, which are the Medicare HMOs. And they come back and they want us to document the HCCs, the hierarchical condition categories, that determine the risk score. And that's because the HMOs are at risk, and their payments are determined by how sick these patients are. So that's why they've been after us. And they're willing to pay an incentive amount of money, because it's a quality issue, over and above the E&M code, to make sure that these things get done. Well, these are not wellness visits. These are visits that are specifically designed to capture all the things that are wrong with the patient and to put in one place all of the plans for taking care of these things. You have to have a plan for each thing that you identify. Again, these are not simple. We've seen through the Medicare HMO programs that they've had a number of ways to sort of help us with this. And we're going to try to do the same kind of thing through Health First Network with these as well. And basically what this kind of comes down to is to do all the documentation that's necessary to cover what's expected for wellness and to cover what's expected for illness. Medicare patients really need 2 comprehensive visits a year, during which all the preventive elements are addressed at the wellness visit and all of the disease elements are addressed at the illness visit. Now, can you split these out over more than one visit? You can, but it's going to be complicated to try to get it all back together again. So we're trying to get people to think in terms of a wellness comprehensive visit and an illness comprehensive visit. The wellness visits do not have a copay, so the patients can come in for those for nothing. Now, if you do anything else, if you do an EKG and an interpretation, that's going to bump up against their deductible, and most of these patients have a Medigap plan anyway, so it's still probably going to be not much. And as I noted, Health First Network is working on a plan to be able to offer a quality incentive for both the comprehensive wellness and the comprehensive illness visits. Where this kind of fits together with some of the Medicare Advantage plans is we know that the ACOs are designed to become risk-bearing in their 3rd year. So we'll be responsible for downside money loss during the 3rd year. We feel fairly strongly that as we move into the next iteration of whatever it is that either is the ACO or takes the place of the ACO, will be risk-bearing. And again, risk-bearing entities are going to be reimbursed on the basis of the sickness of the patients that they have. So we'll be expected to do the wellness things. We also are going to be expected to do the documentation on the illness as well. So all this kind of falls into what we're going to be doing as time goes on. This is an F-22, and this is also an air superiority fighter. This one also has lots of stealth technology. It's a great airplane. Ended up costing a lot of money, so they only made a limited number of these. But they are out there flying around. I'm going to spend a little bit of time talking about transitional care management. And this is something that primarily is being emphasized because of the ACO. And the ACOs are designed to work on what's called the Medicare Shared Savings Plan. So the way these things work is Medicare goes back and looks at our patients over the last year and determines how much it costs to take care of them. That becomes our benchmark. So our benchmark is somewhere in the $800 range. So if we come in the following year at less than $800, we potentially can share in those savings. To do that, we have to hit a minimum savings amount, which for us is about 3.2%. And if we save more than 3.2%, we get to share half of whatever is saved, provided we meet all the quality measures. So it's complicated. It's designed to make us jump through the hoops that that CMS is looking for us to do to put that healthcare delivery system together that provides high quality, high level of accessibility, and lower cost. One of the problems that we clearly have is patients are sent home sicker quicker than they ever have been before. So the likelihood of being readmitted to the hospital is huge. And 1 in 5 to 1 in 6 of all admissions are readmissions. And most of those are probably preventable. And the way that you prevent these things is by finding a way to do impeccable care during the time of transition. Now, transition is any time they change from one level of care to another. When they go into the hospital, you got to do the H&P, you got to write all the orders, you got to get all those things set up. When they leave the hospital, you have to do the discharge summary. Medications, you have to reconcile meds. All these things are part of transition. And transitions are intervals of significantly increased risk for the patient, for the caregivers, and for the providers. So proper care and attention to detail during transition is critical. At the ACO level, we have nurses that will be focusing mostly on transition of care. We've put a lot of our resources into this already, and that's where we're going to continue to do it, because we understand that prevention of those unnecessary readmissions is a significant source of savings. Not the only, but certainly it's a significant source of savings. Part of how this works is on our ACO attributed patients, we have our care coordination nurses assigned by PCP. So a PCP and his office staff and his patients or her patients will be interacting with the same transitional care personnel, the same care coordinating nurse, which we think will really help a lot. We're currently trying to develop methods to identify these ACO patients when they go into the hospital for a couple of reasons. One, clearly those are going to be the ones that are going to need the transitional care. Two, there's a lot of emphasis these days on finding your high-risk patients and trying to intervene. We're going to generate most of our high-risk patients from looking at the patients that require hospitalization. So we actually can kill a number of birds with one stone. One of the problems we've run into is the hospitals are a little reluctant to give us that information. We're working with them. We're starting to make some progress, but it's taken a long time. But we're going to continue to work at that. We are looking at other alternatives to try and develop real-time information. All the hospitals in our area use a particular source for verification of eligibility. And so that particular source we have access to, so we can get information there. All the home health agencies now are cooperating with us, and they are notifying us when one of our PCPs has a patient who is admitted to their service, usually coming out of the hospital. So we're closing in on this slowly but surely, but we would like to identify these patients while they're in the hospital, because it gives us a chance to get started right off the bat in terms of making sure that that transition happens the way that it needs to. It's going to be important for our physicians and for their office staffs to understand that our ACO nurses are part of their team. Let your patients know that they're going to be hearing from these nurses. A lot of the Medicare patients are reluctant to talk to people over the phone who they don't know. So we need some help with this. And so they need to see our ACO nurses as part of the care team, because they really are. So we need our physicians and our office staffs to help us with making sure that the nurses are accepted when they call. We've talked about how complex transitional care is. And here's another area where CMS has finally identified that this is an important thing to do right. They have identified 2 specific codes that have to do with transition of care management. Hopefully you guys are all using these now, but I wanted to go over it again just to make sure everybody understands the complexity. 99495 is a transitional care that requires moderately complex decision making. and occurs within 14 days of discharge. 99496 is high complexity and has to occur within 7 days. If you see a high complexity patient 14 days out, that's going to be billed as a 99495. High complexity within 7 days is what's required for that 99496. Both of these visits require a combination of non-face-to-face contact, telephone, internet, any of those kind of things. And our ACO nurses will be doing a lot of the non-face-to-face contact. They'll be coordinating visits, coordinating the care, trying to get a hold of what information is available in terms of discharge meds, all those kind of things. So you will have those in your hands at the time that you see these patients in follow-up. It also requires coordination with other providers. So hospitals, and again, we're going to try to help with that part of it, home health agencies, pharmacies, any interaction with any of these count towards that transition of care management. And so it's a case of pulling all of these things together and making sure that it's all there and documented. Certainly one of the things that's going to be critical, especially on these short cycle, these within 7-day visits, and it can be within 24 hours, 48 hours. But we'll need for the offices to have visit slots available on short notice for these patients to follow up. It's hard to gauge exactly, but we're thinking most of our PCPs are probably going to have anywhere from 4 to 6 patients of theirs that may be hospitalized by anybody at any given time. Average length of stay is about 4.5 days. So each doc potentially may see one discharge a day or a couple a week. So they'll need to be able to make plans to be able to get those patients in. And again, our nurses are going to try to get a hold of these people as soon as they hit the door on the way in. So we can start planning those things. They can be in touch with your office to try to make sure that those slots are available. Again, this will give you an opportunity to make sure all the documentation is there to bill for these visits. And this is what CMS currently approves for those visits. Again, getting those patients in a short cycle and making sure that that transition goes well is a huge quality impact activity. So we would like to include those as well in some kind of incentive program for our docs, again, to make this more attractive, to do the things that need to be done. That's all I have at this point to present. We're about 35 minutes in at this point, so I'd like to thank everybody for their attention. We'll be putting this presentation out on, we have a YouTube channel. If you go to www.youtube.com and type in Health First Network Inc., you'll be able to get access to this. We're also going to try to get this archived on the GoToWebinar site, and we're also we'll try to get this in a PDF format and probably make it available on our website as well. So at this point, I'm going to take a look and see what the questions are.